to you guys. So basically our objectives, we're going to do our primary assessment. Our primary assessment should be a quick exam over them. This is our quick review over them. Then we're going to go with a focused exam. Our focused exam is going to be trying to figure out exactly what's going on towards the area, our secondary assessment, and our treatment. So when we get to that, our primary assessment is what's our patient's level of consciousness. That's going to be the big thing that's going to drive everything. Are they speaking to us? Are they unresponsive? Are they in and out of consciousness? We're going to check their airway. This is also going to be important because of everything we do when we take our national registry testing, right? You're going to do it step by step, and if you don't ask it, it didn't happen. Now, if I'm talking to you right now, is my airway open and patent? Yes. In the testing scenario, if you don't check the airway, that can fail you. Just pre-warning. I think it's stupid, but it is what it is, so I got to let you guys know that. So is the airway open? Is it debris? Is there any area in there where you hear basically bleeding, slurping sounds, anything else that could be affecting it? Are they breathing? So once they're finding that breathing, okay, great, but what's the rate? What's the depth? What's the quality? You got to find out all those different aspects. And part of breathing is going to be lung sounds as well. So listen to the lung sounds. Is there wheezing? Is there rouse? Is there crackles? Is it normal? Is it abnormal? Junky is a good lung sound to me. It's junky. I can't hear it. It's louder on one side than the other. It just gives you an idea to go look into it a little bit more. What's their work of breathing? Are they using accessory muscles? Are they tripoding? Are they really going at it? Or are they talking to you like I am right now in a fairly relaxed situation? Circulation, basically get that pulse. But your pulse also tells you your BP, right? So if I've got a radial pulse that's strong, probably got a BP over 100. But I'm at least over 80. If I don't have a radial pulse, but I got a carotid, I'm over 60. Femoral pulse over 60. If you can find a brachial, more important with kids, brachial is 70. Get an idea of where your blood pressure's at. But not only that, when I'm checking pulse, be checking how does the skin look? Do they look pale? Are they diaphoretic? Are they mottled skin? Anything like that is going to give you those areas. On the assessments, you got to ask, because when you're looking at a mannequin, they're always pale, right? So on those areas, it's more important. In real life, do you need to ask what their skin temperature and color is like? No, you're seeing it. But for all these lab scenarios, you've got to ask, because if you don't ask, we don't tell you. And when you're looking at a pale mannequin, or you're looking at one of your fellow students who's pink, warm, and dry, you don't understand. So you've got to get used to asking that situation, just for the testing scenario situation. Real life, you guys should know those. And then how else are they presenting? And that restless anxiety, impending doom, and Levine sign or Levine sign, however you want to pronounce it, I'll show you that in a minute. That is very important. And my patients have told me before, I feel like I'm going to die. I feel like it is. And if they say that, listen to them. Majority of the time, they are correct. And they will arrest on you at some point in time. So I always take that into an aspect. What are your pertinent negatives, pertinent positives? Asking those questions. Chest pain, how long? Have you had this before? Does it radiate? All those different things there. Levine sign, basically, that's the clutching of the chest or the arms over the chest. You basically see that area. That is usually cardiac-related pain. That's not non-cardiac related. Get your...
An involuntary reflex that causes that, or is that just...
It's just patients just clutching chest. What it is.
But that's generally cardiac?
Cardiac related with that. This is where you're going to use your OPQRST, and you're going to find out how did it come on? When did it happen? What's making it worse? What's making it better? Those are the specific questions. So if you ask OPQRST on every medical call, it'll lead you right to be at. How many times have you got on a call and you don't know exactly what's going on and you don't know where to go next? I have. You're like, shit, I have no idea what's going on. Sorry for my language. I have no idea what's going on with this patient. So what do? I got to go back to, and I literally ask OPQRST, and I start asking the situation. You will be, I will guarantee you, you're going to be on patients you have no idea what's going on. It's going to happen. I do it all the time. So you got to start being able to ask questions and figure out what it is. And there's times I've dropped off patients to the doc, and I'm like, I have no idea what's going on. I have no idea. It happens. So don't be afraid of that, but you got to have a system that you can figure out what is going on. with them? Or how can you at least get close to figuring it out? And asking these things, well, how did it start? You know, and asking there. And for all you who work on AMR and drop off too, you're going to find too, and this is the hard part, and I know I'm going off topic here, but you ask your patient all these questions and you drop them on the hospital, and the doc asks them, well, how did this start? Oh, I was doing this, 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 and you look like an idiot. You're like, well, why did you tell me that? Well, I didn't remember. You know, or they have totally different things. You find out working in the field and dropping off, it happens. So, but you start asking questions, and all of a sudden you may figure out something that's there that started it. Maybe you found out you were downstairs and I was just doing this. Okay, well, what's downstairs? And you can find out, oh, maybe they've got a dust allergy. Maybe something coming out. Maybe they were down. What were you doing down there? Well, I was working on my my furnace. What's wrong with your furnace? Well, I've had issues with it not working. Okay, why don't I take a CO detector down there? Okay, my patient is altered because he's got CO going on there. We've had a couple cases of that in Spokane like that. So be asking all those questions. So follow your OPQRST, especially when you don't know what's going on. But if you get a consistent level of questioning, the majority of the time you're going to be able to find out what's going on. Not always. So basically here, going over onset. What were you doing? What started it? What brought it on? Provocation. What's provoked it? What makes it better? Is it with activity? With it rest? Is it positional? Anything that's done? What have you done in the past? My favorite question is, have you had this before? If they answer yes, I am excited. Sweet. Is this like before? Yes. What did you do last time? This. Perfect. We're doing that. Ask those questions. Quality. Again, this is hard not to lead patients because I see it all the time. Is it a sharp pain? Is it a stabbing pain? No, just ask me, how would you describe the pain? If you have to give them some leading questions, give it to them. But ask them what the pain is, or ask them what their symptoms are, because we asked one gentleman, well, what's the pain feel like? He goes, I don't have any pain. Okay. Well, what does it feel like? Well, it feels like someone's sitting on my chest and it's just pressure. Okay, what does that pressure feel like? Rate the pressure. Oh, okay. And he talked that, but he said he wasn't feeling pain, he was feeling pressure. But he was basically, someone else may have classified it as pain. So ask those questions. What is it like? What's your feelings of? Maybe it's not pain, but what's the pressure like? Does it go anywhere? Does that make a difference? It can, but it doesn't have to. But ask if it goes anywhere. See where does it radiate? Is this a nerve pain? Is it anything else? You can delineate. This doesn't have to be associated with cardiac. But is this associated with anything else? Does it go anywhere? Any other adjustments that are involved? The severity. 10 being the worst pain. I get people who tell me, just as you guys have too, oh yeah, this is a 10. Yeah, right now. Oh, yeah, right now. And you can tell with that word that I'm in a 10, right? So, and I've had another guy who has his arm completely crushed. He goes, yeah, it's about a 2. And it's like, okay, that would be an 11 on most people. So, but ask where they are with their pain, and again, adjust it by how they're presenting as well. How long has it lasted? Does this progress over a period of time? Where does it go? This is going to be sensitive when they talk about fibrinolytic therapy, but you want to know how long it's been going. Has it been going over 4 days and they finally decided to call you at 3 a.m. because now it's just finally tired of it when it's snowing outside? And then additional questions. Make sure you're doing your follow-up questions, all those pertinent positive, pertinent negatives, anything associated with it. You can kind of see these aspects. Be looking for everything else that's going associated with it. Why are we going to ask if the difficulty breathing was sudden onset or not? PE. If acute, rapid, sudden onto it, then I'm basically going to think, oh, PE should come up as one of my diagnoses. So how does PE present? What can cause PE? So now I can ask along those questions. Have certain questions that you ask that if it pops up, it should bring up more differentials. Again, your goal is to start off with a differential list like this. We've done differential versus field diagnosis, right? You should have a differential like this and start whittling it down until you get to, be nice if you got down to 1, but maybe a couple, so you know where it's at. But get used to asking questions that are going to bring up aspects and put into diagnosis. And when you have a differential, try and delete it out. If you can't delete it out, it's probably one of the things that potentially could be. Allergies are always important on there. Again, I want you guys to get used to asking this OPQRST, your history, including your allergies and your medications, quicker than later. Especially, I've kind of pre-warned you guys in scenarios, if you don't get it off, there could be an allergy There could be a medication that affects the person's condition. So find out. Get that list. At least see if there's a list somewhere you can get a hold of too, because it is going to affect your treatments on there and what you can do. Know what their current medications are. And this is why it's important to know the medication. Know when someone's on a calcium channel blocker. Know when someone's on a beta blocker. Know when someone's on certain medications that are going to affect their heart or other systems and what you're going to do to counteract those areas. If someone's on a beta blocker and they've overdosed on it, what are you going to do for it? What? I can't hear you, sir. Epi? Glucagon is actually going to be the one, but we don't carry enough glucagon amongst everything out there to fix it. But you're going to know, hey, I'm going to call medical control, let them know whoever I'm transporting to it is. But you should have an idea to be able to identify. How are you going to identify if they're on a beta blocker overdoses if you don't know what beta blockers are? So that's why you're going to see as we do these scenarios, we're going to start introducing more and more pill bottles. I want you guys to get used to certain ones, looking them up and getting an idea. The more you see them in here, the more comfortable you're going to be out there. Their past medical history is going to be huge on them. And sometimes you have to ask multiple times. Do you have any past medical history? Nope. Okay. You ever had diabetes? Yep. You ever had heart problems? Oh, yeah, I had a heart attack. You know, you ask them, have you ever had medical problems? Nope, not a one. Okay, why do you have a strip there? Oh, yeah, I had a cabbage done. You know, they'll go over to it. So you might have to ask multiple times on some patients to get a history out of there. That's why it's important also having those medications and knowing those medications before to know what their history is. Smoker, why is that important? Well, we can judge that way, but I know a lot of physicians who smoke who are very wealthy, so it's not they're poor. But basically, that can lead them to clotting factors. It can lead to wheezing. So again, that kind of goes into area why I was trying to have you, and I'll go more into your area of albuterol. We overuse albuterol in a lot of situations where I really wanted to go into. And there's aspects where I would give students a lot of times there's wheezing and no one asked to be smoked. He's smoking because he's got lung problems on there. Albuterol do no effect to that particular aspect of it. But be knowing just what's going on with those smokers. They're going to have increased chances of clotting factors, increased chance of cholesterol buildup, other injuries on there. So those are important aspects to know what leads to your area. What was their last oral intake? Why is this important to us? What's that? Well, for anything in their intake, if this person needs to go in for a pacemaker, yep, they need to know it from that standpoint. Is, again, what this one is specifically going to, and you guys haven't gotten there, you're not going to get there probably till the next module on there, but the gallbladder. You eat fatty foods, it causes pain, and that referred pain can lead to cardiac. If people have chest pain, it was like, well, did you eat something? Yeah, I just had this meal. It was a really fatty meal, stuff like that. And it's because they're having issues with the gallbladder. It actually has nothing to do with cardiac. So you have to find out kind of those things. So having those questions. The guy in the gym who basically is having heart problems and his heart is beating out of his chest. Well, look at his pre-workout, his workout, everything he's taken on there, and he's loaded up on caffeine, and he's exploding his heart out from those aspects. Because you'll see the guys who tend to do that, and they do a lot of things, and they do it incorrectly. They're not doing it right. And so now their chest is beating out of their, you know. So is it related to that? What is it that's starting the problem? What can you rule out and not rule out? And I didn't even look at Jake during that whole time. No, but I did say it correct. I did say it correctly, right? I said the guys who don't know what they're doing. See? Yeah, typically they won't do it, but I've seen people do it incorrectly. And they're loading up multiple things and everything on there. So it's the guys who do it incorrectly. Yeah. No, my best friend, I don't know if you ever knew Paul Hughes, but he worked at GNC and he does all those stuff on there. And if you've done correctly, it's perfect. It helps build the workouts. But it's those guys who do it incorrectly, or they don't follow a nutrition plan, or they don't have a trainer, or they don't have someone telling what they're doing. They just go buy all these random stuff and they just start taking it. So,
What's the difference between your typical, right?
Yeah. There's always that philosophy. So,
It's good. 5 is better.
yep. So events proceeding up to what happened to it. This is also going to be very common. You guys are going to get areas where we're going to give you a patient who's got SVT, and it's from an anxiety attack, right? It has nothing to do with cardiac. It's basically they've got a high stressful situation. The world's coming to an end. We get it from emotional states. We'll get this happening all the time. Were they working out? They were being very active, and that's the rates going up there. The travel time and trauma associated, we're going to talk about those how they events come into it. What were you doing before this? An important question may be, where were you last week? Oh, I was scuba diving down in the Bahamas. I just flew home yesterday, and now I'm having difficulty breathing that just started. So you should have a good idea. Wow, I better be thinking PE on this one. So, and then any time of trauma or anything like that. I just recently had surgery. I've been down for last 2 weeks sitting still, and now I just got up and started walking around. Probably had a DVT that could have thrown and turned into something. So if you're thinking of all those aspects. When we do our secondary assessment, that's going to be looking again over the skin. I still think how the skin presentation of those are is going to be one of my, still in my primary assessment. But how are they doing? How are they responding to your treatments? Going over and doing basically an overall assessment of them. How are their eyes responding? Checking their face, looking for any other complications that may come into. Looking for their neck. Do they have JVD? JVD is an important sign that can be seen. This talks about tracheal deviation. Tracheal deviation is a late sign. If you see tracheal deviation on a patient, you needed to decompress them 10 minutes ago. But JVD, you'll see, will pop up immediately. It's a quick sign of there being problems. Now you have to determine which problems are associated with JVD, but it'll bring in that and it gives you a good idea. What they're basically saying is the best assessment of that is get them at a 45-degree angle, and that's where you see it. If you still see it at a 45-degree angle, then that's truly a JVD, and you need to start looking for what's causing that problems. And there you go. Right there. So commonly here, I've actually used this picture in other slides, so I'm just going to leave it right there.
That's our IV side.
Yeah. Other secondary assessments going over the chest and abdomen. How are they breathing? Are we seeing retractions, accessory muscles? Touch them. Push on the chest. Is there pain with palpation? Okay, that may not be cardiac related. It can be costochondritis, could be rib pain, could be a pleuritis going on, could be lots of different things when they come chest pain on there. Is their abdomen distended? And I have to ask this several times. I go, I'm sorry asking, but is this normal for you? And I ask patient's family, is this normal? Or is that abdomen distended? We did it on a lady the other day. No one was in the room on that call. But the lady had a little distended abdomen. I'm like, is this new or is that normal presentation? I'm not being rude, not being mean, but yeah, it had a little bit of a pooch, if you will, right there. Is that new or is that not? It can have factors. Pulsating mass. Again, we kind of talked about that later. If they have a pulsating mass, you have to push in pretty deep down to get down to the aorta where it sits. And if they have it, that's probably not what's killing them, but you may be able to identify something. But again, when I talk about AAA, that's not going to be my main area. And then ascites, basically that's where it's like the waterbed on there where the fluid is just flowing across there. Be thinking liver function, liver problem issues, other things too. Checking their legs, especially dependent edema. So we talk about pitting edema. Pitting edema is when you've got swelling in a leg and you can push into it. When you move your thumb, there's a pit remains. 4+ pitting edema is basically a depression of can't remember if it's a ½ centimeter or more, and then how long it takes to come up. There's 1+ to 4+ pitting edema. Basically goes to, you press it in, how deep does it go, and how long does it take to come back up? There's also what's called woody edema, where basically you're pushing on it and it's edematous, but it's really hard. All can mean different things. What does edematous legs usually mean to you guys to be thinking of? CHF. Specifically, right-sided CHF, not left-sided CHF. So pitting edema with clear lung sounds, pitting edema with wet lung sounds, full CHF, and that's overt CHF. Does that work for you?
So
I don't know. I'm
full
just making that
CHF,
up.
that's overt?
No, I'm just screwing with you. So, no, nope. You don't even need. Again, this is This is basic stuff. You don't even, nothing from this is being testable per se. And this is that talking about edema, pitting edema. They don't have a, here's a good picture of that. So it's 8 millimeters for 4. So 8, 6, 4, 2. I just do it by scale. I'm kind of looking and does it pit and does it go deep? Yep, it's 4. And it kind of go in, it's 2 or it's 0. You will not be tested on this.
So what else causes
Lots of things can.
other than CHF?
Vein problems where you're not getting fluid out compensated. There's inactivity would build up in poor peripheral vein. A lot of different aspects can.
What most
So-
it's like CHF type thing, or
Not necessarily, but if they're complaining of chest pain and other issues, difficulty breathing, be thinking that is one of your criteria. Definitely be getting your vital signs. I want you guys to be in a habit of using your partners. We do this in real life, but again, in these scenarios that I've talked about, especially our summative scenarios, as a partner, you can't say anything until the person directs you to. As soon as you get there and you start asking your questions, have your partner start getting those vitals for you. And again, your partner in the summative scenarios is going to ask, what vitals do you want? Be specific to the vitals that you want. All of them doesn't work. So when it comes to lung sounds, do not listen to anyone else's at this point in time. I want you guys to be taking your own lung sounds. And what I've told almost all the students when you're in their field, when you are on your field preceptor time, you should be listening to lung sounds on every single patient. They got a stub toe, listen to lung sounds. My same philosophy is on any chest pain related, do a 12 lead. It's pleuritis, do a 12 lead. It is a anxiety attack, do a 12 lead. They complain to chest pain, do it. Reason is the more you hear normal, the more you're going to know abnormal. You guys should get to the point to where you look at 12 leads and you just go, yep, yep, yep. And then when you see something, go, that doesn't look right. Then you stop and you spend time on that. But you should be able to look at a 12 lead and a 3 lead like this eventually. Not now, don't worry. But eventually you should be able to, anytime, either look at a monitor, look at your 12 lead and go, yeah, it looks good. Or be going, wait a minute, I'm going to spend a little bit more time on that. But you shouldn't be spending time on every rhythm strip. That's why I want you to see it so often. The more you listen to lung sounds, the more you're going to know that doesn't sound right. So
listening to heart sounds, or is that?
I can't hear heart tones. You can hear S1 and S2. You cannot hear S3 or S3 or S4 in the field. If you watch Chicago Fire, you can hear B-fib. Yeah. So that was I've got to find the clip, but there is a clip. Basically, she's listening to her. Larry B-fib, go ahead and start CPR. And I'm like, all right. So she auscultated B-fib. I love Chicago Fire, so it gives for great joke. And then glucometry, basically be getting those blood sugars. Again, I am a big proponent of this. They've taken it out of AHA as far as one of the 6 H's. They made it 5, but be taken in there because that does have a huge factor on things. As far as our treatment, oxygen, the reason it's starred is, again, AHA over 94, don't give oxygen. My philosophy is under 99. If my patient's got 94, am I giving a non-rebreather at 15 liters? Absolutely not. I'd probably put a nasal cannula in. Doesn't hurt to put a nasal cannula in with capnography, right? Because I can give, according to Josh, I can give 2 liters, which is perfect on there, and I can get a good waveform. So I can do that. Be given aspirin. Find a reason not to give it. Otherwise, give it. If they took aspirin 4 hours ago, 1 baby aspirin, give them another 4. Give them 3 if you're really concerned about it. I'm not concerned about it. But give them aspirin. Nitro. Do not give nitro to a patient until you have an IV established. That's my philosophy. Get your IV established, and then I don't care if they're in a, Dr. E will tell you the same thing. Go by your medical directors. Let me restate that. Go by your medical director who's overseeing you. So I'll make sure Raby's on the same page. But when you're during the preceptor, you're going to be technically under our malpractice, so you'll be under Dr. Raby. Previously, it was Dr. Edmister. Dr. Edmister said that. So you go there. When you're out practicing your own field, do what your medical direction tells you to do under your department. Fair enough? Fluid boluses. Again, we'll talk about different ways to get boluses out there, but fluid makes a huge difference out there. Dr. E also believes any patient, even me right now, could take a liter of fluids. It's not going to hurt me. Granted, if I have flash pulmonary edema, probably not going to give me a liter of fluid within reason. Dopamine, do they need it or not? Be thinking it on there. We don't use it a ton. I'm going to talk about other aspects. And transcutaneous pacing. Just always be ready there. Have the pads ready to go on every patient. Don't be afraid to get them out.
Everybody's getting pads.
No, but just have them ready. So know your anatomy and physiology. Be able to inspect that. Kind of know where things are at. They're going to talk about auscultating for bruits. Basically, if you feel where the carotid artery is, you're going to take and put your stethoscope there. You can listen it with here. So the way the stethoscope is written, that's going to be side for lung tone. The other side, if you're going to listen to heart tones, use it with the bell. So you'd be flipping that around. That's for heart tones, the flat areas. But basically what you're looking for, and I probably can find, I don't have it in here. Let's look.
Why do you use the bell for heart tone?
Because it confines and it pulls how it listens to specifically for the sounds, because you want to hit it on a specific spot and where you listen to for your S1, S2, S3, S4. But S3 and S4, I can never hear the field. So, but this, what you're looking for is you're looking for a whooshing sound with a bruit. And basically, carotid bruits get a decreased flow, and it also can relate to other type of clotting factors and things like that. Because these basically plaques are building up there, the blood's got to rush around it, so it can cause decreased blood flow. We used to talk about, so in supraventricular tachycardia, I'm going to start, you guys starting to look in the algorithms. If you have a stable patient who's got a fast heart rate, first thing we do is what? What? Vagal maneuvers. So a couple ways to do vagal maneuvers. One is they talk about bearing down. So act like you're bearing down. I try not to do that because I've had patients bear down and they give me a bowel movement. Not fun. So other ways to give that same area is blowing on your thumb, which works really easy because everyone's got a thumb in most cases. Thumb, just, I got a thumb, okay? Yeah, it may not have fingertips, but you got a thumb. So it's blowing down. This is a vagal maneuver right here. Other way you can do is give them a syringe and tell them to try and blow out the plunger. Lots of different things. Thumb, everyone has a thumb. You don't always want to give away one of your syringes because it can be used other ways. So that's an easy way to do it. They talk about carotid massage, basically can give a vagal maneuver. You do a carotid massage on someone with a bruit, you broke that clot through, and you just potentially gave them a stroke. So we don't do carotid massages anymore. If you are going to do carotid massage, you do it bilaterally, and you just hold.
With a belt, right?
With a belt, yes. Yeah, don't do that. So again, did you guys learn anything new per se out of that? Nothing should have been new education out there, right? Okay. Questions? No? Okay, let's get back, be back at 12:30, so I'm giving you 40 minutes for lunch.